కష్టం పడతాను ఎవరికి చదవాలని. Hi everybody. I think I can remove my mask now because I'm all alone in the chamber. So it's raining outside here. I don't know how it is in your places. Anyway, we have started community ophthalmology yesterday, and I've been telling you people that there will be short notes, and sometimes we will ask you in the examination certain definitions. Okay. We have seen actually community ophthalmology actually it is deals with actually appropriate strategies and methods to reduce the burden of eye diseases in the particular community, and there are various basic principles, and we have seen actually the solutions comprising of all these three. And I have told you actually the definitions of blindness. To recapitulate what was told, economic blindness actually it's presenting vision less than 660 in the better eye, the level of blindness which prevents an individual actually from earning his daily bread and butter or daily his wages. And that's the reason actually it is also called work vision. And the second one is actually legal blindness. So the vision is here is 660 or 20/20, 20/200, or visual field less than 10 degrees. So the level of blindness actually necessitates welfare measures and also legal protection for these people. And this definition most often actually it is used in the United States of America. Social blindness is a degree of disability that hampers an individual from interacting actually the family and also the peer groups or their close friends or whatever whoever it is in a satisfactory manner. So the inability to count the fingers at a distance of 3 meters with the better eye, with the best correction. So this is known as actually social blindness. Then this hampers the individual to walk freely also. So it is also called actually a walk vision. And manifest blindness, visual acuity less than 160, it seriously constrains the accomplishment of tasks for daily living. Also impairs mobility of the individual. And it's used as an actually service indicator, as most of the cataract blind in the developing world, such as our country and also the other parts of Asia, so are operated for cataract at the vision when the patient attains actually vision of 160 with the best correction. Okay. Absolute blindness, loss of perception is known as absolute blindness, inability to perceive the light in any eye. And curable blindness, that stage of blindness actually where damage is reversible by prompt management, example cataract and glaucoma, and also we have, suppose if they are treated early, these people they will have definitely relief from cataract. Of course, even if it's an advanced one, it doesn't matter. If we operate and put in a PCIOL, the patient will start having good vision, even 6/6 in most of the cases. And preventable blindness, the loss of blindness that could have been completely prevented by institution of effective measures at the earliest stage, such as xerophthalmia, trachoma, and glaucoma. And avoidable blindness, the sum total of curable blindness is around 85 to 90%. It's avoidable blindness. Incurable blindness, certain things actually we cannot do anything, such as an anophthalmos, congenital abnormalities, all these things, congenital hypoplasia, the disc, all these things we cannot do anything. These are actually incurable blindness. Okay, WHO, as I have told you already, this also we are asking the examination. It accepts a cutoff of visual acuity of 3/60 in the better eye with the best possible correction to define blindness. Whereas National Program of Control of Blindness, visual acuity is less than 660 in the better eye with the best possible correction to define blindness. Okay. So we have seen actually about NPCB. NPCB is a 4-mark question for you people with short notes. We have already gone through all this, and the major causes of main cause of blindness also I told you: cataract, refractive errors, corneal blindness, glaucoma, surgical complications after surgery, posterior capsular opacification of cataract surgery, posterior segment disorders, which I have already mentioned, and others, the congenital abnormalities, all these things they come under that. Okay, goals and objectives also we have seen yesterday. So the major types of refractive errors which are to be provided, correction to be provided in the population are in the children, school-going children, any refractive error, be it actually hypermetropia or myopia or myopic astigmatism or hypermetropic astigmatism. So this will have to be actually corrected by after doing a cycloplegic refraction. The adults after 40 years, because of actually the receding of the near point, so these people, they will not be able to read normally like like the peer groups of other, like the younger children. So the presbyopic correction with a convex lens actually it is to be given. And FAK correction, as I said, actually nowadays it's not needed because most of the cases we are doing an extracapsular cataract extraction. And also the vision actually it gets corrected by the lens we implant actually in the posterior chamber. But for presbyopic correction, because the accommodation is knocked off after cataract surgery, so that will have to be given. The near vision correction actually will have to be given for these people. Okay. Intensive health education activities, we have seen information education, communication activities have also been seen. We have talked about it. Corneal blindness and eye donation also we have seen. World Assisted Cataract Control Program, this we have talked about it yesterday. DANIDA, Danish International Development Society, this we have seen, and International Development of Department of International Development of the UK, which has started actually helping the government of India in strengthening the community ophthalmology also we have seen. Organization of NPCB we have seen, and Vision 2020, this also we have seen. Globally, 5 conditions, as I have mentioned yesterday, they require actually immediate attention for achieving the goals of 2020. First, they will have to tackle the cataract, glaucoma, onchocerciasis, childhood blindness, refractive errors, and low vision. So these conditions have been, we have seen, they're initiated. All these things I think we have yesterday covered it. So targets, glaucoma, we have seen. This also we have seen onchocerciasis, childhood blindness. This always we have seen vitamin C, refractive errors, human resource development and community level. So this is, I think we'll have to stop at this stage yesterday. And primary health care is a fundamental concept of the World Health Organization for improvement in health. So we have actually mother PHCs and also the other small PHCs spread over most of the villages. Okay, so there actually you will have a medical officer and middle level ophthalmic personnel. All these people, all the elements of primary health care actually they can contribute to the prevention of blindness. So a PHC worker he plays actually an important role in the control of blindness. PHC workers, they are ideally placed in the villages nearer to the patients to identify the blind people, and also visually disabled children and adults in their own home. Okay. So assessment and diagnosis of the children, rather the adults or the population which is actually coming with a defective vision will have to be done, and a primary healthcare worker. Normally, we have primary paramedical ophthalmic assistants or optometrists. These people actually, they are tried in the particular field, the ophthalmology, for about 2 years after completion of their intermediate +2. Okay, and they will write the examination just like you people actually, the theory, and also they will have the clinicals and also orals. So 2 years, and later on they will be given actually a diploma known as paramedical ophthalmic assistants or optometry. So BSc optometry and MSc optometry are also there, but the primary healthcare workers, they are mostly paramedical ophthalmic assistants, and these people, they are taught actually to assess the individuals who could be helped actually by the services of a specialist. So initial evaluation can be done by paramedical ophthalmic assistant in primary health centers. So then suppose the common ailments such as a conjunctivitis or a refractive error, so those things actually they do manage at the primary health center level, but the other things actually such as which requires a specialist attention, so they refer the cases to the specialist at the district headquarters hospital or the tertiary hospital. identifying a cataract for referral to an ophthalmologist. All these things they are actually told. Referral PHC workers can encourage individuals to go for treatment and can provide referral system that will promote this. So after the treatment, the PHC worker can follow up the patient. Suppose if we do a cataract surgery here and the patient goes back to his village. So normally the primary healthcare workers, so they follow the patient at their home to help them actually for visual rehabilitation. And the patient after cataract surgery, so normally he requires it actually, how he should use the drops and what are actually the telltale condition of the eye, which actually requires a specialist attention again. All these things actually will the primary healthcare worker, he will be looking after at the PH level. And he also gives our advice on treatment and make sure that the spectacles are available after the prescribed period of around 6 weeks or 4 weeks. So secondary and tertiary levels, ophthalmologists. So normally the target actually we have is ophthalmologists per population. Sub-Saharan Africa in 2000, it is 1 in 5 lakhs population. There used to be 1 ophthalmologist per 5 lakhs. In 2010, actually it has increased to 1 ophthalmologist per 4 lakhs population. And in 2020, it is 1 ophthalmologist per 2 lakhs 50,000 population. In Asia, the situation is a little better. So in the 2000s, actually, we have 1 ophthalmologist per 2 lakhs. And 2010, actually, we have 1 ophthalmologist per 1 lakh. And in 2020, at the moment, it is for every 50,000 population, I think we have 1 ophthalmologist. So Vision 2020, right to sight in India. India was the first country actually in the world to launch the National Program for Control of Blindness way back in 1976. The goal is actually to reduce the prevalence of the blindness. Of the total estimated 45 million blind persons all over the world, that is best visual acuity is less than 3/60. 7 million actually they live in India. So due to the large population base and also increased life expectancy of the individuals. So previously when we were children, actually it used to be around 45 to 50 years, the life expectancy. Now I think it has gone up to 68 years or so. So because of the increase in life expectancy, so the number of blind, particularly due to age-related disorders like cataract, glaucoma, and all these things, age-related macular degeneration, all these things actually it's increasing. India is committed to reduce the burden of avoidable blindness by the year 2020 by adopting strategies advocated for Vision 2020, that's right to sight society. Okay. So the current status, if you take actually the extent of the problem, 3 major surveys have been actually conducted to find out the prevalence of blindness in the country. The first survey undertaken by the Indian Council of Medical Research way back in 1974 indicated that the prevalence rate of 1.38% in the general population, that is visual acuity, the individuals who have a visual acuity of less than 660, it's about 1.38% in the general population. Second survey, which was conducted by and sponsored by the Government of India and World Health Organization way back in 1986 to 89, the prevalence rate increased to 1.49%. Presently, presenting visual acuity is the same thing, 660 in the better eye. As per information available from various studies, estimated 12 million bilaterally blind persons in India with visual acuity less than 660 in the better eye, of which nearly 7 million have visual acuity less than 3/60 in the better eye. So, okay, there are 12 million people with a vision of 660 in the better eye bilaterally in India, and about 7 million people with a vision of less than 360 in the better eye in India. Okay, recent survey, it's not a recent one, way back in 1999 to 2001, in 15 districts of the country, the survey indicated that 8.5% of the population aged 50 plus is blind. Visual acuity is less than 660. The reasons are multifold. So it can be actually a cataract, or it can be because of the refractive errors, it can be because of the glaucoma, it can be because of basiculated macular degeneration, or some posterior segment disorders. All these things could have caused actually this thing. So the main causes of blindness in individuals with 50% population, 50 plus age group. So the first and foremost is refractive errors. It accounts for nearly about 19.7%, nearly 20%. So the maximum junk is cataract, is around 63%, 62.6%. Corneal blindness caused by corneal scars, corneal dystrophies and degenerations and all these things are interstitial keratitis, which leaves back the telltale signs of interstitial keratitis. So corneal blindness, it is around 0.9%. Glaucoma is more common actually in Western countries, and that's around 5.8 to 6%. And surgical complications, after surgery, there will be certain complications. Those people there, which is around 1.2%. And posterior segment disorders, such as retinal detachment, retinitis pigmentosa with consecutive optic atrophy, retinopathy of prematurity, age-related macular degeneration, optic atrophy, all these things actually they account for nearly about 4.7%. Others, congenital malformations or injuries, all these things actually they account for around 5% of this thing. So no nationwide reliable data is available regarding the refractive errors and also low vision in our country, except some isolated studies. A survey in Delhi to assess the prevalence and cause of the blindness and low vision in children aged 5 to 15 years indicated that 1% of the children of this age group had a vision less than 618 in the better eye. So achievements, all surveys actually they indicated cataract is the single largest cause of blindness in India. Controlling cataract blindness was given a lot of priority in India so as to reduce the amount of blindness. So funds were mobilized from the World Bank during 1994 to 2002, even now we do it. So I think recently the World Bank, World Health Organization and World Bank, they stopped actually the funding this project. Assistance was provided to 7 major states estimated to have which are estimated to contribute nearly about 70% of the country's cataract blind. So under this project, following have been the achievements: 307 dedicated eye operation theaters and eye wards were constructed in the district headquarters hospitals, and supply of ophthalmic equipment for diagnosis and treatment of common eye disorders, such as you have slit lamp and direct and indirect ophthalmoscope and gold manipulation tonometry, and all these things actually which were not available prior to that, and they were provided. And intraocular lenses for implantation, they were also provided all district headquarters hospital through the DBCS. More than 800 eye surgeons, they were trained for IOL surgery, and 30 non-governmental organizations, NGOs, assisted for setting up expanded eye care facilities, such as Rotary and Alliance are the major people actually who helped us in conducting the cataract camps in the far periphery, both in rural and tribal areas. So volume of cataract surgery has steadily increased from 1993. Now actually it is far better. In the cataract surgery rate is around 3,800 per million population way back in 2003 to 2004. There has been a significant increase in proportion of cataract surgeries with IOL implantations from less than 5% in 1994 to 85% in 2003 to 2004. So nowadays, most of the cases, almost all the cases, we do actually a ECCE, whatever it may be. It's a small incision cataract surgery or a phaco emancipation or laser-assisted phaco emancipation. We do it and we put in a PCI oil only. Okay. So even if the PC is not there, then we try to rather implant in the posterior chamber itself by way of actually scleral fixation or iris clip lenses, all these things. There has been an increase in coverage of eye care services also. A rapid assessment survey carried out in 14 districts in 1998 indicated that 70% of persons having access to the eye care services. So the access to the eye care services has a lot improved after the advent of this program. So it's a decentralized approach. So you know, the country, India is a very vast, very big country, and the population is nearly about, it's very, very big population, okay? It's nearly having 29 states and 7 union territories and 593 districts. Maybe it's increased also, with an average population of nearly 2 million per district. So the program implementation has been decentralized because you cannot actually have a central thing and implement the program all through unless you have a decentralized approach. So the program implementation has been decentralized up to the district level by District Blindness Control Society, DBCS. It has been set up as the nodal agencies. Members of the DBCS include officials from district administration, health, education, and social welfare departments, media, community leaders, and also NGOs and private sector. They were involved in the eye care. So these societies directly receive funds from the government. The concept is to establish a bottom-up approach in dealing with the blindness through multi-sectorial and coordinated efforts. These societies are also responsible for identifying blind in every village, organize diagnostic screening camps at suitable locations. Normally, we used to have the schools. We used to conduct actual camps in the schools, arrange transportation of the patients from the local area to the district hospitals or to the designated facilities where actually we have the designated facilities. And later on, after the treatment is over, after the surgery is over, we used to ensure actually follow-up of the individuals. So monitoring and evaluation, following tools have been developed for effective monitoring of the program. Standard prototypes for reporting of performance and also expenditure by the District Blindness Control Society. Standard cataract surgery records and patients' discharge cards, they were also provided. And standard referral card for children having a refractive error, and specific software to facilitate computerized MIS at various levels. These are all these things actually they provided for monitoring and evaluation of the program. So we used to have actually, even now I think we have a sentinel surveillance units, nearly about 25 units they were established way back in, I think around somewhere in 2000. And they were set up in the departments of ophthalmology and also preventive and social medicine in medical colleges for assessment of beneficiary profile, one. And secondly, visual outcomes based on cataract surgical records and follow-up of subsample of operated cases to assess visual outcomes. So ocular morbidity data also collected to assess patterns and trends of the eye disease. So sentinel surveillance unit, it was established in the medical college in the departments of ophthalmology and also the preventive and social medicine, community medicine. So National Surveillance Unit, it was established actually in the Department of Community Ophthalmology, Dr. Rajan Prasad Center for Ophthalmic Services, All India Institute of Medical Sciences, New Delhi. The functions of this unit are establishing a database for all the blindness control activities in India, and secondly, providing technical support for the network of sentinel surveillance units which were established actually in the medical colleges in the ophthalmology and community medicine department established. So disseminating information on trends in blindness control activities in the country. And fourthly, developing information resources and relevant software package for monitoring and evaluation of the program implementation, including mapping of services for end users. So the fourth one is actually independent studies have been undertaken to evaluate the program activities. These include communication needs assessment, beneficiary assessment, evaluation of trained eye surgeons, and rapid assessment for estimation of prevalence and coverage and outcome. Epidemiological survey on blindness in population years 50 years plus. In 15, epidemiological survey in blindness 50 years plus in 15 districts. Quality of services, substantial efforts have been made by discouraging outdoor surgical camps. As I told you, actually, way back in 1980, we used to conduct the eye camps in the far periphery, being the tribal areas, rural areas, select a school building or any function hall and fumigate it, conduct the camp the day before. Investigations are done on the spot and select the cases for surgery. And we used to do the surgery in the far periphery only. And that we used to do only in an intracapsular cataract extraction. And that necessitated actually FAK correction in those individuals. And we used to prescribe, give the glasses also, FAK glasses. Okay. So nowadays, actually, we are discouraging the outdoor surgical camps. So we are not doing surgeries at the periphery. So emphasis on IOL implantation at institutional level is encouraged always. Emphasizing follow-up of operated cases and greater coverage for women and underprivileged sections of the society. So normally, after the surgeries or any surgery, we ask the patient, we see the patient the next day morning, remove the patch and see them. And again, we try to see them again after 1 week and again after 28 days. According to the NPCB, this is the protocol. Okay. So the program is being implemented in collaboration with the Centers of Excellence in the government and non-government sectors, which have emerged as leading training and research institutions capable of taking a leadership role for shaping eye care programs, not only in India, but in the other countries as well. So these institutions have excellent infrastructure, human resources, and patient volume required for imparting training and conducting research. There is a close coordination, formal and informal, between these institutions in the country. So, situational analysis of eye care infrastructure and human resources, I don't think you require all these things. This is not, anyway, for completion's sake, I'll just read it out. Situational analysis of eye care institutions and human resources in India, conducted by Ophthalmology Section of Director General of Health Services, Ministry of Health and Family Welfare, Government of India, and RP Center for Ophthalmic Sciences in 2002 to 2003. An attempt was made to collect information on infrastructure and human resources for training as well as service delivery in the whole country. So data was collected from two different sources: teaching institutions for assessing the status of ophthalmology training, and secondly, District Blindness Control Society for assessing infrastructure for eye care services delivery in the districts. So this is more important for the post-graduates. These data were supplemented by the other sources like a MAS database and from the private hospitals. Performance of cataract and other eye surgeries. ECCE IOL was the commonest procedure for cataract surgery. Phacoemulsification, small incision, nowadays we are doing it for cataract surgery. Gradually, nowadays for every case almost it is the same. So the other surgeries which we perform actually in a case of in a medical college is trabeculectomy for glaucoma. So whatever type of glaucoma depending upon the indication. Squint surgery. And usually here we do actually horizontal muscles, vertical muscles normally we don't try to touch it. We leave it to the pediatric ophthalmologist. And keratoplasty, we don't have the tissue. We have done a few working in Kakinada and Rangaraya Medical College and also Regional Eye Hospital. And vitreoretinal surgery, there are certain centers here. And DCR and DCT, we had a quite good number actually while working in Regional Eye Hospital, Andhra Medical College. So mean number of ECC and IOL per medical college per year is, they mentioned it like 1,215 operations. So nowadays, of course, in our college, in Gayatri Medical College, we have not reached that stage yet because we don't have enough patients. But the other centers actually they are doing about 6,000 to 8,000 cataract cases per year. Okay. On an average, 866 other eye operations were performed, such as I have already mentioned, squint, trabeculectomy, keratoplasty, post-segment surgeries, DCR and DCT and all this. Ophthalmic equipment, most of the colleges had all equipments related to the cataract surgery. I tell you, before actually 1994, we never had even slit lamps in the colleges. So there was a survey to assess actually the status of ophthalmological services in all the medical colleges by the central government, and later on they have provided actually all the equipment needed for modern gadgets needed for actually for evaluation and also the management of eye disorders. So eye care facilities and human resources, about 47% of all eye care facilities, they are in the private sector. 49% of all eye beds, actually, they are in the voluntary sector. Government sector, it has contributed only 33% of the facilities and 28% of the eye beds. 37% of eye surgeons were employed in the government sector, and the rest were evenly distributed in the private and voluntary sector. Wide interstate variation in eye care facilities and human resources were observed in this study. Vision 2020, the right to sight, was launched in India on October 10 to 13, 2001 at Goa. A working group was constituted by the Government of India for preparing the plan of action and strategies on Vision 2020, the right to sight initiative in India. The working group met at Manesar and Lucknow to develop the plan of action. The draft plan of action was submitted by the working group to the Ministry of Health and Family Welfare in 2002. Though it was initiated in 2001, it was submitted in August 2002. And this was approved in principle as a document for future planning by the National Program for Control of Blindness in India. So there are certain target diseases identified in Vision 2020, which include the first one is cataract, childhood blindness, refractive errors and low vision, corneal blindness, diabetic retinopathy, glaucoma, and trachoma. Human resources needs. There is a need to develop around 2,000 service centers, each with 2 ophthalmic surgeons and also 8 ophthalmic paramedics, and 20,000 vision centers need to be developed, each with 1 ophthalmic assistant, community ophthalmic assistant or equivalent. Eye care managers will be required at the service centers. Community eye health specialists will be required at the training centers. So paramedics, mid-level eye care personnel, 2 streams of such personnel are required. One is hospital-based, all categories like nurses, refractionists, ophthalmic technicians, assistants, theater personnel, they're all needed actually. And community and vision care center based, these persons will be responsible for school eye screening, refraction, and primary eye care, tonometry, etc. So objectives for the year 2002 to 2007 to improve the quantity and quality of cataract surgeries, even at the rural level, development of pediatric ophthalmology department in training centers and also centers of excellence. To screen known diabetics for diabetic retinopathy in the clinics and to screen greater than 35 years attending the clinic. Low vision services to be initiated at tertiary level with adequate linkages with secondary level and primary care in a phased manner. Development of safe eye banks and networking of eye donations and training centers. Integration of primary eye care with primary health care throughout the country by training medical officers and ophthalmologists and other para. Sharma class lo unna tarvata phone chestane. So the eye care infrastructure is center of excellence. We have nearly about 20 and training centers around 200 and service centers around 2,000 and primary level vision centers in the villages. We have around 20,000. The infrastructure pyramid given above is based on the structure recommended by the World Health Organization. Under the National Program for Control of Blindness, a conference on primary eye care to support Vision 2020 was held on April 11th to 14th, 2002 at Coimbatore. So the participants include the members of the working group and also experts in the field of primary eye care in India. So the recommendations of this meeting are focused on: one is infrastructure and support for primary eye care, and second one is human resource development and training needs, and the third one is models for service delivery and community participation. This is not necessary for you people again. Infrastructure and support for primary eye care. Vision centers, they are very, very important. Vision centers are established for primary eye care to a population of 50,000 in the rural areas. Primary health centers are the next one, and cooperative. This actually primary health, in the primary health centers, it is managed mostly by middle level ophthalmic personnel, such as ophthalmic, paramedical ophthalmic assistant or optometrist. The target is post one middle level ophthalmic personnel for nearly about 50,000 populations throughout the country by 2020. That's the idea. Functions of Vision Center, actually identification and referral of minor external eye diseases such as conjunctivitis, eye injuries, all these things, they will have to be referred. And vision testing and prescription and dispensing the glasses, they do it there itself. And school eye screening programs, they will have to do it, the paramedical ophthalmic assistants working in the vision care centers. And eye health education, so they will have to teach them actually the various do's and don'ts regarding eye health. And the training of volunteers, suppose if there are volunteers who want to actually learn about these procedures and later on work in vision centers, so they can be trained there. And identification and referral of glaucoma, cataract to the service centers, to the district hospitals or to the base hospitals for surgery and IOL implantation. The personnel for primary eye care, to deliver primary eye care, following personnel need to be involved. First and foremost is area-specific involvement of volunteers from the local communities and also non-governmental organizations, and 2 teachers from each middle school also they are involved, and health workers posted at sub-centers and PSCs, and middle-level ophthalmic personnel, and medical officer, PSC, and general practitioners. Examination process, the facilities for following examinations need to be made available at each vision center to carry out functions at the primary eye care. One is they should be provided with actually torchlight examination with assistance of a magnifying loupe. So even we used to do it actually way back in the early 90s. And the retinoscopy, including cycloplegic refraction, we teach them actually the people in charge of it for prescribing glasses. And Shiar's tonometry, it is a portable tonometer as you all know, and the tension can be taken, especially for the individuals who have a family history of glaucoma in their family, and who are above 40 years, they will have to be, their intraocular pressure will have to be taken at regular intervals with a Shiar's tonometer, because it's a portable one. And furnace examination by the medical officers. So the primary health centers, so the medical officers in charge there, they can be taught actually to see the fundus, to identify the major disorders and to refer them actually in case of necessity. And National Program for Control of Blindness should provide following steps to develop PEC facilities, primary eye care facilities. So equipment which is needed at vision centers are trial set, trial frame, vision testing drum, plane mirror retinoscope, streak retinoscope if at all it is possible, Snellen charts. So these things, and Binomag or magnifying loupe, Shiar's indentation tonometer, torch lights with 2 batteries, lid speculum, epilation forceps for epilation purpose in case of trachoma and trichiasis, foreign body expert or needle for removing the foreign bodies also, and direct ophthalmoscope for use by the medical office of the PSC, and rechargeable batteries, because the non-rechargeable batteries, they prove to be a little costly. So the drugs which we provide actually at the primary health center are cyclopentolate eye drops for inducing cycloplegia, propamide eye drops, xylocaine eye drops for removal of actually the foreign bodies and also for taking intraocular pressure. So for any milder cases of conjunctivitis, all these things actually you can as well use the antibiotics such as ciprofloxacin, chloramphenicol eye drops, tetracycline eye ointment, ciprofloxacin eye ointment, neosporin eye ointment, and for dry eyes actually an artificial tear can be given, and oral supplementation of vitamin A solution and also the capsules can be given in case you see actually xerophthalmia case. So the materials or the registers which you will have to maintain at the PSC level are so blindness register, referral cards for patients needing further evaluation of PSC, and vision card with prescription for glasses, and flip book for eye health education, charts and posters, do-it-yourself vision testing posters, cataract card for health workers. So all these things will have to maintain. Spectacles, free subsidized spectacles will have to be given for children 5 to 15 years, and also for the people who undergo cataract surgery and who were aphakic at the time, actually they were given actually free spectacles. Human resource development and training needs personnel to be trained in primary eye care, medical officers at PHC, staff at PHC and subcenters, school teachers, village level volunteers. All these people, they were trained actually in regional eye hospitals such as in Andhra Medical College, regional eye hospital we have in Vizag. So training needs assessment should be carried out after defining the job responsibilities of the above personnel. Village level activities could be contracted to local NGOs and self-help groups, and this should allow decentralization to become a reality, and it would be a sustainable model. This include optical cooperative units. It is proposed to develop mobile primary eye care kit for the health workers and also volunteers. The kit actually contains simple questionnaire on primary eye care and common eye ailments, and also simple tips on how to deal with these ailments. Eye care education should target the following: mothers regarding the hygiene, eye hygiene, and the nutrition, which is important for eye care, and prevention of injuries. So all these things the mothers should be taught. And children regarding good reading habits, proper illumination, and while they are playing at the safety to be taken, all these things the children must be taught. And teachers regarding identification of symptoms using simple checklist. And training on primary eye care should include drip training, 1 hour thematic training at PSC for transfer of skills related to primary eye care for health workers and village level volunteers. So cascading training to function as a team, training of teachers should include refractive errors and common eye symptoms, do's and don'ts, as I have already mentioned. Training of VHW should include skills for vision testing, diagnosis of operable cases of cataract, and monitoring use of spectacles. All these things will have to be village health workers. Need to develop modules for training different functionaries. I don't think it's necessary for you people. Childhood blindness, again, this is important. Pediatric ophthalmology facilities should be developed in tertiary care hospitals, and existing eye surgeons need to be trained in pediatric ophthalmology. And there may not be a need to create a separate post of pediatric ophthalmologist at this point of time. And training of ophthalmic surgeons in pediatric ophthalmology for merely about 6 months or more. Defined tertiary eye care centers should be done, and support development of pediatric ophthalmology team, including pediatricians, anesthetists, and middle level ophthalmic personnel. In case a hospital is already doing a pediatric ophthalmology services, some support systems may be required actually to develop pediatric ophthalmology facility. Equipment required in pediatric ophthalmology need to be provided, especially for squint evaluation, and also even the vision done actually in the children, it is a little different. So not with this routine Snellen's chart we take the vision, as more than half of the childhood blindness is avoidable. Emphasis should be given and laid on the prevention of childhood blindness through cost-effective strategies. So low vision and refractive error screening within a specified period of admission to schools should be done by schools in collaboration with the District Blindness Control Society and District Education Department. Address the organized sectors initially for screening and managing presbyopia, screening and services for refractive errors, low vision. So this is I don't think it's necessary. Corneal blindness is another thing actually which we lay a lot of importance. Emphasis on hospital retrieval system or the corneal button in a dead. To get better donor material, there is an urgent need for assessment of number of people who would benefit by corneal grafting, because the demand and supply is not going hand in hand. Actually, we have a lot of demand for corneal grafting. There are a lot of more people actually with corneal blindness than the supply of the corneal material, corneal graft. For vitamin A supplementation, we should focus on areas that are economically backward. Priority should be given to the slum population, tribal areas, and drought and flood-prone areas, and migrant population, nomads. So post-T segment disorders, one will have to take care of it. Actually, it's in the tertiary hospitals we do it. Medical retina services need to be developed in tertiary care centers. These units shall attend to various post-T segment disorders, primarily diabetic retinopathy or retinal detachment, which is posterior vitreous detachment, proliferative retinopathy, retinopathy of prematurity, all these things. Awareness about diabetic retinopathy should be created in clinics. Managing diabetic patients, a small pamphlet on diabetic retinopathy needs to be developed by the physician. Some inexpensive screening mechanism for diabetic retinopathy should be established in diabetic clinics. On a pilot basis, fundus cameras can be introduced in some clinics, and they are located centrally where diabetics can be invited to have pre-fundus photographs. We have actually fundus photographs in our hospital. We are taking fundus photographs of the individuals whenever we conduct actually diabetic camp. And we are in the process of actually evaluating the data. We have a common program, common project with the engineering college people. The project is funded by the DST, only about 23 or 24 lakhs. And patients of age-delayed macular degeneration need low vision services, such as magnifiers and all these things. And linkage needs to be established between medical retina services and low vision services. Advocacy and public awareness, not necessary for people. Human research development. Ophthalmology as a separate subject in MBBS course, it is already there, not necessary. Desired ratio of ophthalmologists and MLOPs in hospital should be at around 1:3 to 1:4. Explore feasibility of 3 months resident program in selected institutes during year. Database. This is in brief regarding the community ophthalmology. I think tomorrow we start, I'll tell you about the ocular manifestations of systemic disorders. If I complete it tomorrow, that's fine enough. Otherwise, it may be on Monday. And from then onwards, I think we'll give you some topics. And you'll have for seminars, and you'll have to talk about it. You'll have to prepare and talk about it. Anyway, I'll announce the topic tomorrow. Okay. Thank you. If you have any doubts, you can ask.